we should think about how to prevent this death due to preeclampsia. There are so many things we have to discuss, and because it is raining heavily outside, nobody will be traveling outside and sit at home and log in and enjoy the talk on preeclampsia, which is going to be given by none other than Professor Sangeeta. Sangeeta is a very brilliant, eloquent, and knowledgeable person. That is why I preferred her to be today's speaker. And she is the professor and HOD of Government Medical College, Alappuzha. She has a career spanning 26 years in medical college and has been filled with academics and teaching, driving passion in working with reduction in cesarean section rates and maternal mortality. She is also, like me, an assessor of the confidential inquiry into maternal deaths. And she's a captain of the maternal near miss surveillance and response and a trainer of ORRT. And she's a member of the State Medical Education Unit and Vice Chair Board of Studies, Kerala University. She possesses an avid interest in public health and trains in Women Health University of Kerala. ഈ ദക്ഷിതയൊക്കെ ആയിരിക്കുമല്ലേ? So I invite Professor Sangeeta. Before that, I want to introduce Chair and Sir. Actually, don't need any introduction. Sir is an international figure among us, one of the very few international figures among us. Sir was President KFOG in 2003, Vice President Foxy in 2010, and founder president of NSSTDI. You may be logging in every 8th of every month with a webinar on gestational trophoblastic disease. And Sir has conducted a World Congress on GTD, Secretary and Treasurer of ISSTD, and authored several FIGO guideline. In the FIGO guideline on trophoblastic disease, Sir's name is there. Sir was one of the authors. And Sir has 55 publications with more than 500 citations. Let us start without wasting time to Dr. Sangeeta. I'll stop sharing my screen.
Thank you, Madam. Good evening, respected Prasanna Madam, Shekharan Sir, Subhash, Kunimoydin Sir, Sati, Ajit, all the people who are online. I'm very thankful that I've been chosen for this. I hope I do my job justice. Right at the beginning, let me make my excuses right in the beginning. I have an extremely bad cough. So after 5 minutes, I will start coughing, and that cough starts from somewhere in the toes. So I'll keep drinking water. So I may have a little bit of disturbance in between. Now I'm going to share my slides. Can you see the slides? No. Can you see the slides, Madam?
Yes.
Yes, ma'am.
Yeah, fine. Let me just put that on slide share. Okay. So when Madam had said we should try and discuss what should be the timely decisions that have to be made in preeclampsia, there are a lot of timely decisions. I've taken some complex and some simple, and I'm sure Madam will put in the rest. And Shekharan Sir, of course, with his undying love for eclampsia, will offer the expert comments at the end. So when you look at hypertensive disorders, nothing really has changed. We've been looking and talking about that it is a multi-system disorder, unknown etiology, protein manifestation. It presents for the first time in pregnancy. It is specific to pregnancy but doesn't require a fetus. Nothing has changed from then. Only thing that has changed is now we see preeclampsia without hypertension in 15%. We may not have both hypertension and proteinuria in another 5%. And sometimes we are stymied for a diagnosis. So I'll start by saying that maternal mortality and morbidity is still extremely high with preeclampsia. It's ranked second in Kerala. And as I said, hypertension alone is not a marker. And we have to think, do I need to predict? That is, do I need to really do a screening test on the patient and figure out, is she going to develop preeclampsia? Can't I just be very conscientious, see my patient regularly, take her blood pressure, and as soon as I find the increased blood pressure, start treating? Is that enough? And if I do screen, what do I have to offer? So I'll just go a bit into that. So if she's screen positive in 2026, the best we can do for her is to give her aspirin. It has to be 150 milligram. It can't be 75. And we start right early at 12 weeks because we know that preeclampsia is a angiogenic disturbance. So the trophoblastic invasion into the arterioles starts at the first wave. Aspirin, we hope, will open up the circulation. So you must start it early. And when we screen, not only does it offer us the chance to start aspirin, it also helps us to watch these pregnancies much more carefully. That stringent watch is extremely important. You can also employ additional tools like the biomarkers, placental like growth factor, or you could use SFLT and figure out, is the process more severe? Is it going to come in the next 4 weeks? Am I going to land up in a catastrophe? That is also the biomarker can also be used as a tool to time your steroids. Why do I say that? I'll come to it a little later. And also in some severe cases to whether to get them into the hospital as well. So the next argument is, if I'm going to screen and spend so much of money and give a tablet as simple as aspirin, why can't I just give aspirin to every woman? It's a cheap drug. It's freely available. All government hospitals will give it to them free. So why can't I just do that? Then I save about 5,000 rupees or 3,800 rupees. So one is definitely the issue of compliance. It does cause a degree of acidity and heartburn in pregnancy that's totally unwarranted if it doesn't need to be given. And you will need to treat almost 208 women to prevent one preterm preeclampsia. So that also is an issue. And however small they may be, the complications of bleeding exist with aspirin. Very rare, but it exists. So, as a physician, you do no harm. So, if it's not required, you don't give it. If it is required, you give it, especially in pregnancy. So, if not aspirin, or rather, in addition to aspirin, what else has been studied to prevent preeclampsia? Calcium. WHO endorses it, and they say that calcium at 2 grams per day is extremely good for calcium deficient individuals. Pravastatin is a lipid lowering drug. It was studied in Indonesia. It's called the Innovasia study. It very small numbers. It has been shown to bring down early onset preeclampsia, but there is no hard and fast rule. It's not proven. All the rest, fish oils, rest, progesterone, heparin, metformin, esmoperazole, all have really not stood the test of time. So why does this woman get preeclampsia? If we understand that, then we can decide how we are going to pick her up early. So we've established that it is an abnormal placentation. The trophoblast burrows ineffectively into the spiral vessels. There is both the systemic endothelial dysfunction and a widespread inflammatory response. If I was to sum it up in 3 words, it's an angiogenic placental syndrome. So we must understand what is severe about preeclampsia. Blood pressures reaching 160, 110. Any abnormal biochemistry, hemolysis, elevated liver enzyme, lower platelet, abnormal RFT, LDH that is rising, all that will form part of severe preeclampsia. If she goes into eclampsia, it is only eclampsia, it is not severe preeclampsia or preeclampsia with severe features. coma, pulmonary edema, acute tubular necrosis, any imminent symptoms. If she says that she has headache, nausea, blurring of vision, epigastric pain, decreased urine output, these are all alarm bells. And the last thing I've put there, proteinuria is not even today in the triad or in the armamentarium to diagnose preeclampsia, and it is definitely not a criteria to diagnose severe preeclampsia. You may get a lot of protein in the urine. It just means that the glomerulus is opening up, the capillaries are becoming very fragile, and she's throwing protein. But just because it is 4 grams doesn't mean that it is severe. And once estimated, it does not need to be repeated. However, having said that, there's a caveat to that, that once you have severe proteinuria, that is when it is in the nephrotic range, 5 grams, you should start looking for other diagnoses. Is the kidney involved? Am I dealing with an IgA nephropathy? Am I dealing with an SLE? All these are things you should think about. But just on the basis of proteinuria, it does not make her a severe preeclamptic. So when you want to predict, there are hundreds of pathways. So we are happy with the history, which we've been doing from time immemorial. Foxy was very good enough to give us the gestosis score. There are others, the full pyres, the mini pyres, the prep Ps. All these tell you the severity of preeclampsia. Mean arterial pressure is an extremely, I'll go into this, but mean arterial pressure is an extremely easy thing to estimate. Uterine artery Doppler also extremely easy, can be done by the general gynecologist and can be done along with your 11 to 14 week ultrasound. The PLGF is the entity that very many of us all over have not started using it. So that is another thing that I'll come to. SFLT, all the other PAPA, when you get your biochemical markers for aneuploidy, look at the PAPA. A low PAPA may tell you FGR, it may tell you placental syndromes, it may tell you increased predisposition to develop preeclampsia. The last among them is the ophthalmic artery Doppler, which is the thing of today, but has not started being used in routine practice. But it is apparently so easy, we all could do it ourselves. I'm not going into the gestosis score, just to tell you that there are score 1, score 2, and score 3. And the score 3 is all your pregestational diabetes, chronic hypertension, mental illness. Till today, I can't understand why mental illness is in category 3, but it is. Inherited thrombophilias, your renal disease, autoimmunity, SLE, APS, ART, all will give you a score of 3. And once your score reaches any one of those or any 2 plus 1, you need to start aspirin. Now, in this, you must understand when they made the gestosis, previous history of a hypertensive disorder comes only as 2. But in the Western guidelines, which talks about all these as an a priori risk, that is, inherent factors in the patient that will put her at risk for preeclampsia. A previous history of hypertension makes her a high risk woman. So also does a multiple. But all these, so my recommendation is that the gestosis score is put up in the OP. Sometimes it may be difficult to remember. Students will come and say, interpregnancy interval, some gestosis score says 7 years, ACOG says 10 years, somebody else says 5 years. So you put up the score in your OP and score every patient that comes to you. In early pregnancy, at first visit, and decide, do I need to start on aspirin?
Sangeeta, you want a few minutes of rest?
No, it's okay. It's all right. I have water.
I have not asked the K4 president and secretary to address those who have logged in. Let them address and then we'll.
Fine. Perfect. Perfect.
Hello, Subhash. Hello, Dr. Fesi. Fesi is there? Subhash. Kunjumaideen.
Madam, good evening.
Good evening.
Good evening, sir. Good evening, madam. Good evening.
Thank you for giving the platform.
Thank you, ma'am. Thank you, ma'am.
You can address those who have logged in.
Yeah, I don't want to be in between the academic session, but in
No,
spite of
but
that,
Sangeeta is having some cough, no, so she will
yeah, it's a great initiative by the Safe Motherhood Committee to have such interesting and important topics to be discussed for all the KFOG members. And I believe many Foxy members from outside the state also might have logged in. And we have this same presentation, same webinar is simultaneously available as a live stream in the YouTube as well. So I hope this academic initiative will do a long support for all the gynecologists practicing in the state to have an updated knowledge about the preeclampsia prevention, screening, and the treatment as well. So best wishes, ma'am. Thank you.
Thank you, Dr. Punjamadi. Sangeeta, are you ready?
Yeah, I'm fine, madam. So put up the gestosis score in your OP. When she comes in early pregnancy, score her and decide, do I need to start aspirin? Do I not need to start aspirin? And remember, aspirin will take care of almost 65% of your early onset preeclampsia. So you must be giving it when it is required. So this is the Western high risk and moderate risk. You need two moderate risks to start or any one high risk, but it's almost the same. So when you do when you screen with just history, you just pick up about 50% of these for a false positive rate of about 10%. Not really very good with only history. So when you add, which is the crux of preeclampsia screening, when you add your maternal factors, which is your a priori risk, which is all there in all these scores, and you add a mean arterial pressure, and you add a uterine artery Doppler, you get 83% less of detection rate for preeclampsia less than 32 weeks and almost 68% after 32 weeks. It is much more effective for screening for preeclampsia, which is early onset. When you add PLGF to this, to the maternal factors, to the mean arterial pressure and the uterine artery Doppler, your detection rate jumps up to 90%, which is actually very good. So there's a SPREE study which tells you that this, when you do the 11 to 14 weeks scan and just do the nice maternal characteristics, is not very good. It's only 40 to 50% pickup. But when you do everything together, it gives you a bit better pickup. So this is the screening program for preeclampsia study. Just for you to understand, in case people have forgotten, how you measure a mean arterial pressure, you take the systolic blood pressure plus 2/3 of the diastolic blood pressure. And normal values outside pregnancy is about 60 to 100. In pregnancy, any value greater than 85 is significant. But we are not looking, remember, as in the aneuploidy screen, we are not looking at individual values. We are collating the whole thing, putting it into the computer, which will give you a risk. And that risk, if it is more than 1:100, then that woman is at very high risk of developing early onset preeclampsia and aspirin must be instituted. So when you take this mean arterial pressure, it's extremely important. One, to reiterate the fact that BP must be taken at every visit and with the appropriate sized cuff. That is something that all with growing obesity, very many women will need a larger sized cuff. And so that must be provided at every point of care in the hospital. Patient must be seated. The arm must be at the level of the heart. She should have rested. She should not have had coffee for some time. And you take two readings on each hand and take the average. But at least take one reading properly. So if you argue and say that, I deal with a very poor kind of a population, they are not going to be able to afford PLGF. So what can I do? So you dual stage your patients. You take history, mean arterial pressure, and that's your first stage screening. If the screens is positive, that is, with the history and the mean arterial pressure, if your screening is positive, Then you apply uterine artery Doppler and PLGF and start all these women with on low dose aspirin. See, again and again, the aim is so that once you screen, you are extremely vigilant if she is high risk. And then you pick them up early, you treat them properly, you get away with not much problem. This I just want to mention. Nicolaides and his group in the UK, they looked at peripheral vascular resistance as a direct predictor by looking at an ophthalmic artery Doppler. And in women with preeclampsia, he found that there was a decreased impedance to blood flow when compared to normotensive women. And this ophthalmic artery Doppler actually showed two systolic peaks. So that's the first and the second peak systolic velocities. And the ratio of the second to the first. So you have the second wave and you have the first wave. When you take the ratio of these, it predicted preeclampsia with far better ease and far better detection rates than any of the others. And I have not tried it myself, but we all must. It's fairly easy to do. It identifies the ophthalmic artery just medial to the ophthalmic nerve or the optic nerve, and you take measurements. She sits with her eyes closed. You take measurements from both eyes. Ordinary, your 15 megahertz linear probe is enough. And the angle of inclination 20 degrees. Sample gauge 2 millimeters. The depth you have to go is about up to about 4.5 centimeters. And this is what you get. Not yet come into routine work, but they are at it. So once we've done something, so at the end of it, we have decided we will screen by whatever means we are going to screen. If she is screen positive, we will start aspirin and we will very vigilantly watch her. Now, we have been taught from time immemorial severe preeclampsia is delivery, which is true and 100% true. But there are instances when you push a little bit. Why? Because it's not that the mother gains anything, actually, the mother loses. But every day the baby remains in utero, it translates into a 2% increased survival, especially when the pregnancy is remote from term. So let's take the case of a 19-year-old primate. She presents to your casualty with a BP of 170, 110. IV levotiol given, magnesium sulfate also given. Then in 4 hours, you feel like a fool because her BP is normal, she's fine, there's no headache, nothing. You've switched to oral, her BP is well under control. No imminent symptoms, biochemistry, everything was sent on admission, biochemistry is normal. So can we prolong this pregnancy? For people who are interested in reading, the group from the North America, Sibai, is the person who's done the maximum amount of work with severe preeclampsia remote from term. And as per those guidelines and as per what we teach, once you have a severe preeclampsia, if you need to prolong the pregnancy, it's a very careful decision making. It should be made only in a tertiary level setup, intense surveillance, because it's a fine, the boat could rock both ways. And any minute it could tilt, the balance could tilt. And therefore, you must be ready to terminate at any instances, and she must be directly under your eyes. So, in this woman, we already, because she came, she was preterm, we already gave her steroids. And then what happens? Nothing happens for weeks on end. And then you're worried whether I need to give her another dose of steroid. Will I be causing brain matter, white matter problems in the fetus brain, leukomalacia, porencephaly, all these may be issues. So, we must take those candidates and segregate them who definitely need delivery. Those will be the severe hypertensives not responding to any antihypertensive. You've gone to the maximum doses of 2 or maybe even 3, but still no response. She has imminent symptoms. She's getting into help. Her liver enzymes are elevated. Her creatinine is rising. She's got hemolysis, lowered platelets. She's got stroke or an MI, pulmonary edema, which is the dreaded complication in preeclamptics and is the one that kills. Eclampsia also, immediate delivery, abruptio or worsening RFTs and LFTs. And when I said pulmonary edema, I must reiterate the fact that pulmonary edema, not only does it kill, it is often iatrogenic because we fail to understand that it is preeclampsia per se is a constricted intravascular compartment and we push her with fluids. And the vascular system is so fragile, she will be pushed into pulmonary edema very quickly. What were the fetal reasons that we would terminate? If the baby is bad, has bad Dopplers like absent or reversed end diastolic flow, then extreme prematurity, severe preeclampsia, you do not wait. IUD or if she has any lethal abnormalities. Now we'll come back and bounce back to this steroid. Do we give the steroid at 34 or do we give it at 36? Now the RCOG will say 36. The American College will say 34. By and large, we don't give it after 34. And we must understand that there is a difference between giving steroids for lung maturity in the preterm and in the FGR preterm. Because the FGR preterm is as opposed to the ordinary preterm, already has the one who is complicated by hypertensive disorder has a small constricted placenta. That baby is already stressed in utero because it has a hostile intrauterine environment. So its endogenous steroid is also high. On top of that, you give her steroids for lung maturity. The small placenta may not be able to clear it and you may land up with problems with white matter. This has largely not been proven, but definitely when you have FGR or severe preeclampsia, we will give steroids only up to 34 weeks, not go wait till 36. When we talk about PLGF, it is a placental-like growth factor. So it's a good thing. It allows the placenta to grow. And there is actually no single cutoff factor. You need to extrapolate it and put it along with the other markers. That is along with the a priori risk, the mean arterial pressure, the uterine artery Doppler. But when you do your second stage screening, your uterine artery Doppler and PLGF will come into the picture. Even though they say there are no cutoffs, there have been cutoffs that have been published. Very high values, 100 and more, 100 pikes or more, the test is negative and the patient is fine. There is unlikely to be any placental dysfunction. Unlikely if she has preeclampsia also to progress to birth within 14 days of the test. But if the PLGF is less than 12, it's a highly, strongly positive test. It's highly abnormal. And this suggests that patients have severe placental problem and preterm birth is very likely. In between is the value between 12 and 99, where they are definitely at increased risk of preterm birth. So PLGF as well as SFLT. SFLT is just the opposite of PLGF. It's anti-angiogenic. So where that was pro-angiogenic, this is anti. It causes vasoconstriction. It ties up the syncytium into knots. There's endothelial damage and doesn't allow placental perfusion to go well. And SFLT is actually said to increase 5 weeks prior to the onset of the disease. So you can use these biomarkers to time your steroids to figure out whether she's going to land up in a catastrophe in the next 4-5 weeks. And look for that optimal time period at which to bring the baby out to a healthy mother. There came the thing of SFLT and PLGF ratios. And when they said that when the ratios were less than 38, it had a very high negative predictive value. That means the PLGF was very high, which is a good thing. But remember, all these predictions are only short-term predictions. That doesn't mean that if I do the test at 14 weeks, I can say that till 37, 38, she's fine. No, it goes on only for about 5 to 6 weeks. And these ratios, when they increase from 38 to 85, there is a increased risk. And when it is more than 85, there is a high risk of imminent eclampsia as well as delivery with a median of about 6 days. So sometimes we all face the fact that aren't we worried? Is this a preeclampsia? Is this a hypertensive disorder? Because she doesn't have hypertension, which is there in 15%. She only has severe edema. And very often, severe edema, people get worried, they get her admitted. Then what do we do? So you estimate the protein. If there's only proteinuria and nothing else, is it a renal disease? So these are the situations in which all your SFLT and your PLGF will help you. Again, the question comes, woman with a normal blood pressure, 130/80 is our goal. She's not on any antihypertensives, but can she be a preeclamptic? She can. Let's say she was a gym goer, very well exercised, she had extremely good vagal tone, and her starting of blood pressures were 170 in the first trimester. And then later on, it creeps up to 130/80. Again, you don't need to start treating, but you must watch these pregnancies very, very carefully. Then you wonder, she's pouring protein in the urine. Is it an SLE flare? If she's postnatally, am I dealing with the TTP-HUS? So you must also understand how to differentiate SLE flares from severe preeclampsia. Hypertension is there in both. Proteinuria is much more in preeclampsia. You can have an active, very angry urinary sediment with RBC casts and everything in SLE. What I would like to say that complements, we always look at complements in SLE and try and prognosticate the disease as to whether the complement is low or not. But remember, in pregnancy itself, complement values rise. And therefore, if you have a normal complement in pregnancy, it actually means the complement values are low. That is what is important when you're thinking of SLE. So when you have a severe preeclampsia, must I do a cesarean section for all of them? Not really so, but very often they land up in cesareans. But you can give them an induction of labor. It is not contraindicated in the stable patient. I'm not talking about the patient who has very high fluctuating blood pressures. No, there the only thing that you can do is bring out the placenta. So deliver her as fast as possible and the patient will be cured. But remember that in most of these instances with severe preeclampsia, they're remote from term, cervix is not good, abnormal biochemistry will always tell you that you will have a shorter induction delivery interval. So the chances of her having a cesarean are high. Having said this, sometimes you find that she comes at 36 weeks with a high blood pressure. Till then, she was fine. At 36 weeks, 140/90. And you send her home and say, come back in 1 week, I'll induce you in a week. So she comes back in a week, 160, 110, and throws a fit. So these late appearance of hypertensive disorders also mean that the system is not very acclimatized to the hypertensive changes. The BP can accelerate, and very often it means an intracranial bleed. And therefore, late occurrence of hypertension, be very, very careful. You don't need to admit them. You could keep them under observation. But when she goes home, tell her about the warning signs. Tell her she must look at her blood pressure every alternative day or twice a week at least from a local hospital. And write and give her the cutoffs and tell her to report back if they are above this. This is extremely important. When we take these women up for cesarean section, you must discuss with the anesthetist. I've given her magnesium sulfate. It can synergize with so many of the muscle relaxants, which they may be using for general anesthesia, which they are going to use for general anesthesia. So I must tell my anesthetist, I must look at my platelet counts prior to the cesarean. She must not go for a spinal anesthesia and have a spinal hematoma. So you must have her PT, APTT and INR. Anesthetists don't say all this for no reason at all. You must have one just prior to surgery. And if you're dealing with a very severe preeclamptic, go through a vertical incision. Sometimes it's easy to say, but maybe difficult to palpate the liver and feel a hematoma. Do an ultrasound before you get in and just look at the liver before you actually get in for a cesarean with a severe preeclampsia. The postnatal follow-up is extremely important. You can't neglect these patients. BP control and targets are as in the antepartum period. And we start, you can give the better control is affordable in the postpartum period, because now you can use your AC inhibitors and your ARBs, which you could not use in the antenatal period. So you start there, these are the maximum doses for all these, whether it is nifedipine, enalapril, amlodipine, or levetolol, they are safe for lactation as well. So you can go ahead and give it. When you start, this is another thing, we all know, I'm not going into how to start, what to start. When you start levetolol, it is a first line drug. Western economy believes in an insurance-led guideline, and therefore levetolol is a much more expensive alternative, and therefore it comes first. But we have Nicardia, which is a very good, cheaper, as good drug. Before, I'm not saying don't use levetolol, but if you're thinking of a very early onset of disease and you're starting levetolol, think that it could also cause a small but definite increased risk of having a FGR, because it is a beta blocker as well. And look at the pulse rate prior to starting levetolol. Starting levetolol with a pulse rate of 60 and 50 may be dangerous. So examine your patient, take her pulse, simple things, pulse, blood pressure, all this must be taken. This is also in the postpartum, just to tell you that don't jump. That is from one drug to the other drug. Morning I gave her Nicardia, it didn't work. Afternoon I start, or her BP was 140/90. So after afternoon I started. I also started levetolol. That is not the system. What is that? If you look at this, if you can see, they say that you need 5 to 7 days to reach a constant, especially if the BP is hovering at about more than 140/90. If it is in the severe range of hypertension, definitely don't wait 5 to 7 days. Increase your dose much earlier. But you can use an extended release preparation of nifedipine, enalapril, amlodipine, or levetolol, and you can make your dose and go to the maximum dose of a particular drug before you start another. Better not to do polypharmacy. And even to de-escalate, if your BP is less, you decrease the nifedipine by the starting dose is 30 milligram per day. So you decrease it by 1 dose, 2 doses, and even levetolol. Decrease the dose by 100 or 200, and then watch her blood pressure. At the same time, are you going to keep them in the hospital till her BP is 120/80? Not required. I'll come to that later. But how will you follow up these? These women should come back to you in 72 hours. That's important. Or at least to go to a local physician who knows what he or she is doing to look at her blood pressure, because this early postpartum visit, they usually come to show the baby. So tell them to come and see you as well and look at their blood pressure, and make sure that you have a late postpartum visit, one at 12 weeks, when you may still find hypertension, and label her as a chronic hypertensive. And remember, like as for GDM, these kind of women need to have advice regarding their lifestyle, their cardiac testing, their diet, their mental health problems, their exercise, and their cardiovascular risk assessment. So they need to be followed up as well. Now, we've seen this so very often. She goes back home 6 days, comes back with seizures. Not the typical presentation, what you call an atypical eclampsia. It is to be treated as eclampsia. You bring her blood pressure under control, but you must think of an alternative etiology. You think of atypical eclampsia when either she has normal blood pressure and eclampsia, the onset of eclampsia is much into the post delivery period, or the fact that when she comes, her BP is normal. So, in these, you think about alternative etiology and definitely ask for a neuroimaging. You ask for the neuroimaging, and you may need, this is the instance when you may need the help of your neurophysician. And you must think of cerebral venous thrombosis, vasoconstriction syndromes, and everything else. Metabolic, you must think. So, imaging the CNS is extremely important. Suppose she is on magnesium sulfate, creatinine is high. Should I stop and watch? Should I switch to another anti-epileptic? Should I half the dose? Should I think of dialysis? So I half the dose, but I watch that carefully and I call my nephrologist. While on magnesium sulfate, her patellar reflex disappears. Do I stop the infusion and keep quiet? I ask for serum magnesium, and then if it's normal, I continue. I recheck all parameters, or I switch to another amp. So these are the kind of situations in which you must look for a serum magnesium. If you have recurrent seizures while she's on magnesium sulfate, think of another etiology. Or you have given suboptimal doses of magnesium sulfate. This is again just whatever I said, just the reiteration of this, looking at frequent blood pressure monitoring. And we all know no preeclamptic will cross 37 weeks. 100%. Only the chronic hypertension without superimposed preeclampsia will be terminated at 38. And your biochemistry must be done frequently. If she's a mild hypertensive, the blood test must be done every week. You can do what is called a mini profile. Doesn't need to be the extended profile. If she has severe hypertension, maybe more than once a week, at least twice a week. If she's extremely severe, it's admitted and probably 12th hourly. What is the goal of our blood pressure? Not to make it 110/70. The placenta also needs a pressure head. So 135/80 is, or 130/85 is the thing that is synonymous with most of the groups. And the trigger to start it is 140/90. Not higher, not lower. I think I shall. Lebitlol, again, I put that in red so that you avoid in patients with bradycardia. Think again if she has bronchospasm or asthma. So just because the guideline says Lebitlol first line, don't go blindly, check and then give. This is my last. So madam wanted me to put the synopsis of whatever I did in 2 slides. So I named it the 10 Commandments to say that what science, the 10 Commandments that science gave us. God gave Moses the 10 Commandments on Mount Sinai. Science gave us 10 Commandments to save mothers' lives and to manage preeclampsia well. So what are these promises we will make? I will screen for preeclampsia. With whatever test, I will screen, and I will use a two-stage process or a one-stage process, but I will pick up those women who need aspirin. I will take blood pressure at every visit and use an appropriate size cuff. I will add on a urine dipstick for proteinuria as well at every visit. I will go behind the hypertensive disorder diligently with both home BP recording as well as biochemistry. Whether weekly or bi-weekly will depend upon the severity of the disease. Will aggressively manage severe preeclampsia and terminate with steroid or magnesium sulfate cover wherever appropriate. I will not procrastinate in using magnesium sulfate. Magnesium sulfate loading dose can be given to anybody, irrespective of what her creatinine is or not. It should be given. I will not procrastinate. I will give it in a timely fashion, even before I refer the patient. I will be very careful about sudden accelerated hypertension in late pregnancy. It spells doom, and I will treat aggressively with IV labetalol. Will definitely terminate all my hypertensive disorders of pregnancy by 37. Will call women for early postnatal care and assess them as well. And I will use my hypertensive disorder to use it as a public health opportunity to steer women to lifestyle modification and a healthier menopause. Thank you very much.
Thank you, Sangeeta. In spite of your cough, you have very clearly and emphatically made it. You have 100% conveyed the message. Thank you so much.
Thank you, madam.
And you are the best person to convey it. Over to Sharon, sir.
Okay, can you switch off the slide, please, Sangeeta?
Sorry. Yes.
Okay,
Stop here.
okay, that's made everybody's life very easy with so Dr. Sangeeta's presentation. She has covered everything in a very clear way, practical points and some of the theoretical aspects. I may touch upon some of the area which she has already covered. So I don't have anything to add on to her presentation, but I will touch upon some of the points what she has presented so far. I may add the definition of preeclampsia, which is now approved by the International Society for Study of Hypertension in Pregnancy. It's approved by FIGO, NICE, and ACOG and others. As per the 2018 definition, preeclampsia is de novo onset of hypertension, which is a blood pressure of 140, systolic blood pressure of 140 and above, and or a diastolic blood pressure of 90 and above. It is and or because either of it is hypertension in pregnancy with no new onset proteinuria as per the definition. In the absence of proteinuria also, as Sangeeta has already said, it can be preeclampsia provided there is evidence of other organ system involvement or dysfunction, as it is in renal, liver, brain, or hematopoietic system or blood stream. If there is any other values which are showing dysfunction, that is also preeclampsia with hypertension. Or if there is evidence of placental dysfunction, as evidenced by the uterine artery Doppler findings, umbilical artery Doppler findings, or other evidence. And later in 2021, they have added the angiogenic abnormalities as evidence of placental dysfunction. That is, abnormalities of the ratio of PLGF, SFLT PLGF, or abnormal developed PLGF itself is an evidence of placental abnormality is equal to that, and in that way that is also preeclampsia with hypertension. As you have very clearly said, sometimes the blood pressure may not be that high and there can be confusion. There is proteinuria, whether it is renal cause and other things. That situation, probably the biomarkers will help to make a decision to diagnose preeclampsia, because if it is SLE and other things, the biomarkers will be normal, but in other ways so that is one of the things. Regarding the screening, the history and other physical or maternal factors will pick up almost about 40, 45 or even maximum 50, whatever is the method. And that is where the FMF method is superior, where it can be early onset preeclampsia can be up to 90% can be picked up, which no other method can pick up. Now, why we are not offering? Are we to offer the down screening in any pregnant woman? I think we can offer, whether doing or not doing is up to the patient, but you have to offer. So accordingly, you can offer the FMF method, even though you need not do the placental growth factor study, which may cost you about 2,000 rupees, which is available in Kerala. It is there in Kerala, it is used in India. So only thing is you can offer this test, which will pick up rate for the screening is almost going to 80-90% if you add all those things. Even if you are not doing, once you are doing the screening for the down screening, just another 2 or 3 minutes will pick up the uterine artery Doppler study. That will add on to the maternal factors, plus we are doing the down screening, the PAPA will also can be added. Even if you don't do the PLGF, your pickup may go up to 60-70%. So at least, so these things can be offered to a patient, whether they like take it or not. But we must be aware of it. It is all available in India also. So you can offer. As we are to, as per me, I think we should tell everyone that there should be a down screening for every pregnant woman at the appropriate time. Along that, if you add this formula also, you can do a screen for preeclampsia also. As you very correctly said, though aspirin is, low dose aspirin is safe, it is having some side effects and problems, and it can cause bleeding during delivery, hematoma formation, even vaginal delivery resulting in intracranial hemorrhage in newborn. So it is not that harmless, but it is safe. So give only for the patients who are positive by screening. That you have very well stressed, and that is again I am stressing that point. Don't give to aspirin for every pregnant woman. Do some sort of a screen, whether it is gestosis score or the NICE guideline or FMF or the risk factors as said by the ACOG, give some sort of a pickup. The maximum pickup of a screen positivity by doing the FMF is only 10% of the screen population. So why do you risk the 90% of the people who are not going to develop the preeclampsia? Don't expose everyone to the. So that was very important point that you have stressed. Then regarding the blood pressure control, you said in the postpartum period also, the level of blood pressure that we have to achieve is 85 diastolic. 85 diastolic. We are not stressing on the systolic, because once you achieve 85 diastolic, the systolic may be 130 or 135. So if you aim at diastolic of 85 with your first line drug, that is good enough. If it goes below 80 diastolic, please stop that medication, recheck the blood BP again and again. If she is going up again above 85, restart the drug. So sometimes regarding the question of your patient who was having diagnosed as a severe preeclampsia, again, as per the present concept, there is no classification of preeclampsia into severe and mild, because the mild case which you have put it as mild can develop into eclampsia and complication and have problems. So don't classify. Nowadays, we don't classify it into mild and severe. So we can say, as you have said, that preeclampsia with severe findings like severe hypertension and other findings. So those patients are to be carefully monitored, and the timing of delivery depending upon it. Now, how this placenta, the biomarkers are going to help us. The patient is preterm and having evidence of some pregnancy which is, hypertension which is not getting controlled well, and you are not very sure. If the ratio is done, the critical or high risk values for a PLGF, the SFLT PLGF ratio, if it is more than 100, more than 200 below 32 or 34 weeks, it's a high risk for developing complications. You may with other findings. By itself, the ratio is not to be taken as an indication for termination. You go with the clinical and biochemical and Doppler findings. Along with these high values, it may be easier to make a decision. Why? Because in our study of 2000 to 2020 to 24, I think 4-year period, we had about 104 or 105 cases of hypertensive disorders, of which only 3 were chronic hypertension. 101, 102 cases of preeclampsia death were there in the 4-year period, which was very high, 19% of the total maternal deaths, of which there were 50+% of cases developed eclampsia. You know, the preeclampsia may not be preventable in spite of your aspirin or otherwise, but eclampsia is a preventable condition. And we had more than half of this death in preeclampsia was due to eclampsia, which means our timing of delivery or management of eclampsia and timing of delivery was not correct. 35% of them developed HELP syndrome. 30%, 33% had cerebral hemorrhage in that study, in our Why Mothers Die study. So that means, as it was said very clearly, that our timing of delivery in cases of preeclampsia has to be very accurately. That is very difficult to make a decision. In such a difficult situation, now you may ask for a SFLT PLGF ratio, which is costing almost 4,000 to 5,000 rupees. Now we have to weigh this 5,000 rupees is worth enough. It is definitely worth to save a young girl's life. It is definitely. So that way it comes useful to us to make use of such things. We can't say that is highly advanced, and our girls are also highly required for our society, and they are young girls who are being lost. So don't worry about the cost and cost factor and other things. It is a question of saving a life. So in case of doubt, use these available technologies which is available with us. So 5,000 rupees it may be, but the life is much more worth than this 5,000 rupees. So that is way. So Dr. Sangeeta, you have covered everything, very excellent presentation, especially that 10th commandment or the oath. I have taken it as my oath in life if at all I see a pregnant woman. It's an oath or command, whatever it is, it has to be followed. Hypertension is a condition which we can treat with the available medications and methodology. You covered everything about the taking of the blood pressure and other things which are important. So very nice presentation. I don't know whether I have to add something more. I will keep on talking, so I will stop here, and because
Thank you,
I
sir.
have to stop. Thank you.
Thank you very much, sir. This is your favorite topic also, isn't it, sir?
Every topic can be separate.
Um, we all in the MD and MSR meetings, we insist that every OP there should be a copy of the Justosis score. I think they are all keeping a copy of the Justosis score and to start aspirin. Somebody was asking when to start aspirin. Everybody knows it is 12 weeks, as early as 12 weeks. If not
before
before,
16 weeks. If it's a cutoff is to be effective before 16 weeks. That is the idea. Even if you are missing 12 weeks, 13 weeks, 14, but at least before 30 weeks, 16 weeks, at bedtime, at a dose of 150. That is what Sangeeta was telling. So before 16 weeks. Even though it is 12 weeks is ideal, but at least before 16 weeks. That is the study findings. It is effective before 16 weeks. Even if it is 22 weeks, you may give. You may give.
as Dr. Sangeeta and Sharon sir emphasized, the role of PLGF and SFLT. If possible, we have to do it. And this uterine artery Doppler, what we thought was it is very sensitive in picking this preeclampsia patients, but we found that it's not that sensitive in picking up preeclampsia patients. We may start aspirin seeing in the uterine artery Doppler, but it's not that sensitive. And we have to be starting doing PLGF and SFLT, as Dr. Sangeeta said, and Sir also said, you can differentiate between other conditions which can mimic preeclampsia, so that you can say it is preeclampsia only. And what about heparin and aspirin? Heparin and aspirin we may give for autoimmune disorders, but if somebody has a previous history of one or repeated early onset preeclampsia, we are justified in giving heparin and aspirin. One or more early onset severe preeclampsia. What is the latest?
Until unless it is for a treatment of SLE or that antiphospholipid antibody syndrome, or for treating such condition, then only. But for a prevention of preeclampsia, it is not recommended. Heparin is not at all recommended.
Patient who had lost one or two babies because of early onset severe preeclampsia, the recent recommendation is to give, you can consider giving aspirin and heparin.
You can think of any thrombotic condition there in the mother. You have to prove it. Just for prevention of preeclampsia, without proving that it's a condition of this thing is not the present recommendation. It has to be given for this conditions. It has to be. Just history may not sufficient. You have to, when you investigate, you may get these conditions diagnosed, APLA or other conditions. So that is where you have to give it. But just for prevention is not there. It's not there until unless you prove that there is a condition.
Madam, there are questions about
Sangeeta.
Madam, aspirin in patients with subchorionic hemorrhage in early pregnancy ultrasound. Should we give aspirin or not?
There is bleeding, don't give. The bleeding has stopped, we can give.
Yes.
And what about exercise in pregnancy? See, bed rest will not prevent preeclampsia or eclampsia. Exercise should be advised for all pregnant women. It will prevent everything unless she has a serious heart disease. So we should all be advising pregnant women to continue to do exercise, at least walking for half to 1 hour in the morning and evening. And when it comes to labetalol, very early, if you give labetalol, it can produce growth retardation or restriction also. That is also there. As Sangeeta said, it should be nicardia. Very early, it should be nicardia. And another thing is when a patient is on large doses of labetalol, like 200 milligram 3 times daily or so, all her receptors are blocked. When she goes for a PPH, she doesn't have the system to accelerate the heart rate or increase the BP. So that should be kept in mind. We had a patient who was on labetalol 200 milligram TDS, and it was a triplet pregnancy, and after cesarean she had PPH, and she suddenly her BP disappeared because all her receptors are blocked. And I think there is an antidote for that also, IV glucagon or something. And this delta hypertension, Sangeeta has said, but the word delta hypertension she didn't say. And when it comes to investigation, serum creatinine, supposing her serum creatinine in the early pregnancy or mid pregnancy was 0.4 milligram percent, and it becomes 0.9 milligram percent, it should be taken as something serious. And if you have a facility for SFLT and PLGF, you can go by the ratio or the value of PLGF and SFLT. That's something which I wanted to say. And then Sangeeta sufficiently emphasized the management of 160, 110 impending eclampsia. We advise the eclampsia kit should have 2 IV cannulas and should be inserted on both hands, and simultaneous labetalol and magnesium, and the full dose of magnesium. And when you refer patients, that is what we see in our analysis. When we refer patients, when the patients are referred from periphery, they will refer with incomplete, inadequate doses of labetalol. It should be full dose of magnesium and full dose of labetalol. And on the way, if there is a delay, there is a tertiary center is far away, then of course he can give nicardia also, which is long-acting than labetalol. That's another point which I thought I'll mention. And then this preeclampsia patients after cesarean, we should be very, very vigilant in preventing pulmonary edema. So once when I took rounds, after 9 p.m., a patient who had a cesarean section for severe preeclampsia, she is on IV fluids, IV paracetamol, IV magnesium. All this fluid will add on to their intravascular compartment. So she was dyspneic, her respiratory rate was high, and auscultation revealed that she has pulmonary edema. So this is a situation which we have to be very careful, and don't give any IV analgesic, or the fluid should be greatly restricted. And she should be looked for pulmonary edema. If pulmonary edema sets in, we may lose the patient. But if renal failure sets in, we can recover the patient by this sustained low efficiency dialysis. So many methods of dialysis are there. So she should not develop pulmonary edema. And even if it is renal failure, we can afford it. Iatrogenic pulmonary edema should not occur. Spontaneous pulmonary edema, very, very rarely only I have seen because of preeclampsia, eclampsia pulmonary edema. It is because the fluid that we give causes the pulmonary edema. And I thank Sangeeta for the very informative and complete presentation. Let me ask all the senior members who have logged in, starting
Just
from...
one point, Prasanna. Just one point. That is IV fluid restrict to 80 ml per hour. Whatever way, all the IV solutions has to be monitored, and it should not be more than 80 ml per 60 to 80 ml, especially for eclampsia. Restricted to 80 ml per hour with all the IV fluid that you are giving. Just one point about the newborn.
Weight also, patient's weight.
Yeah, about the newborn, in mother who is getting Levotrol for especially long term administration, the baby can have baby can have bradycardia and hypoglycemia. So you have to tell the neonatologist or whoever it is that the patient was on, and there is a possibility of bradycardia and also hypoglycemia that is more pronounced in such babies. So that has to. And we said about the for the patient as a contraindication for severe asthma and other things, it is a contraindication. That is all one of the conditions. So we covered everything on that.
Very early onset severe preeclampsia always exclude immunological autoimmune disorders.
Yeah.
Okay, come on. I have sent a faculty link to seniors.
Hello, madam. Congrats, Prasanna madam and Sangeeta for selecting Sangeeta for this topic. Very well covered. One or two important point. There is a typing error in calculating mean arterial pressure.
Yeah, it is diastolic.
Plus wonder, because those who do not know, let them not go with that. Mean arterial pressure is systolic BP plus 1/3 pulse pressure. That's the typing error also. Then regarding, as madam told, already on high dose of beta blocker, they will not respond to vasopressors. Similarly, if they develop anaphylaxis, they will not respond to adrenaline also. So you can say, not related to this, but have to remember. Then postpartum period, often we are a little relaxed once the patient delivers and she is discharged. So tell them very specifically, if any headache, they have to report immediately, because it could be press, it could be venous sinus thrombosis, which may be life-threatening. So even after discharge, postpartum headache is very important. Then thromboprophylaxis, I think Sangeeta has already covered. Then delta hypertension, madam has already told. That is important because many patients, maybe the BP is 90/60, they will go on like that. Suddenly they will have a 130/80 BP. So at this point, even if it is less than 140/90, we should be very careful, because they can go for seizures, they can go for all the complications. That is very important. So I think after next, then my sir has already told SFLT, PLGF. In situations where we want to postpone delivery for a few more days at least to prevent prematurity, we can utilize this. It has got a good negative predictive value. If it is more than less than 38, we can safely continue pregnancy for at least 1 week. Again, repeat. That way we can prevent prematurity and the complications to the baby.
Thank you, Radhabia. Jyoti? Jyotiക്ക് വേറെ മീറ്റിംഗ് ഉണ്ടെന്ന് തോന്നുന്നു. ബീനാകുമാരി, സതി, എല്ലാരും പോയോ?
Dr. Sati is there. Dr. Jyoti has come.
Good evening, madam.
Ah,
It is a very excellent talk by Dr. Sangeeta and great inputs by Shekharan sir. Shekharan sir is looking very smart and young. I think after his birthday.
Thank you all for the good wishes and kind words. Okay, once again. Okay, right.
Another thing just I wanted to add was we have found that there is increased instance of acute kidney injury these days, and lots of people needing dialysis with severe preeclampsia HELP syndrome. So definitely a urine output measurement is very important, and we find so many patients being referred like severe preeclampsia and giving Maxelf without catheterization. So that should be kept in mind. And some people are writing labetalol half BD. That is what they are prescribing. So
Homeopathy.
actually, yeah. So that practice should be corrected.
Should
And
be-
I think the first drug should be Nicardia and then labetalol, madam?
Yes, yes.
Yeah,
First should be Nicardia.
Nicardia. Yes,
If it is a late onset, then of course Nicardia can be started.
yes, ma'am.
See the pulse.
Sometimes Nicardia has patients a headache, then we may have to switch
Yeah,
on. Renal edema, both this will be
yeah.
troubling. And in that situation, we can go with labetalol.
Pedal
And
edema
those
is a complication of most antihypertensives, but usually it comes after a few years of its use.
What's it?
Pedal edema is a complication of most antihypertensives.
Clear
And
formula, Sangeeta.
No, it is true that pedal edema usually follows a long-term administration of antihypertensive.
yes,
But in pregnancy, usually in these conditions, we give for a few weeks or maybe month. But in acute situation, it is only for few days only. So there it may not be a matter. But as everybody said, Nicardia is a good drug to control the blood pressure even in severe hypertension. That is as good as the IV labetalol or even better than. The action may be seen in within 10 minutes. Probably IV labetalol may take 15 minutes. So it's a good drug. The plain nifedipine is a good drug to control high blood pressure. Immediate control can be achieved and then follow up with these things. So that's a good drug. Even if you don't have IV labetalol, give nifedipine when you are transferring at least plain tablet or 10 milligram along with the loading dose of magnesium sulfate in severe cases can save the life. So don't forget to give the antihypertensives for transferring at that time. Yes. Good. Professor Sadi, let us know.
Excellent presentation, Sangeeta madam. You have once again and again proving that you are an excellent teacher. And congratulations to Prasanna madam also and all team in the Safe Motherhood program. As actually, madam and all the discussions have been very fruitful. And again, I would like would like to emphasize the point that if the hypertension starts early, we have observed that giving labetalol may cause predisposed to fetal growth restriction. Am I right, madam?
Yeah. Yes.
And also nifedipine is the preferred drug. But I have one doubt: if she develops hypertension in the late period and in labor, which is the better hypertensive, nifedipine or labetalol? I think it is labetalol because nifedipine has got a slight tocolytic action, and so I prefer labetalol during that time if a woman develops hypertension during that period instead of nifedipine. Please correct me if I am wrong. I feel that way. And also a few discussions in the chat box. Someone has asked whether we can give Lasix in the after delivery for in high BP. Actually, Adam has correctly answered that it is given the indication only indication of Lasix in the postpartum period or during pregnancy is pulmonary edema and nothing and should not be given to reduce BP because that can cause intravascular like vasoconstriction that and can predispose to many other problems including deep vein thrombosis. So Lasix and all the
postpartum period,
this,
excuse me,
yeah,
postpartum period, Professor Sati,
yes, yes,
there is
sir,
a reabsorption of the edema fluid or interstitial fluid,
yes,
and that can come, and that may even increase the BP. So in the postpartum period, there's no contraindication if you want to give a diuretic. There's no contact. It is in the antenatal period, especially the postpartum period when you know the physiology of the reabsorption of the interstitial fluid going on to the circulation, causing hypertension or increase in the blood pressure at that time, probably it may be safe to an oral Lasix may be safe if you think so in the after delivery. But during pregnancy, the only indication, as you said, and everybody knows, is pulmonary edema. That is the life-saving procedure you may have to do. Otherwise, there is no place for diuretics in the management of preeclampsia or eclampsia in the antenatal period. But in the postpartum patient is having edema, which is getting aggravated, knowing the physiology of reabsorption and then causing hypertension, it may be given without much harm. Not to withhold if it is.
We can prefer thiazide diuretic.
Yeah. That's a milder one that can be
You
given.
can exercise her leg.
Okay, point noted.
Exercise her leg.
But after delivery, we are not that much worried. It is immediately after delivery of the placenta, all things return to normal. So we are not worried of aggregation of the condition. But inside with the placenta inside the uterus, it is going on. The pathology is going on. It is only after delivery of the placenta or the trophoblast to the acute minute thing. It has to be out of the uterus for the resolving of the symptoms or syndrome or the pathophysiology going on. So once it is out, you are not that much worried. So once the delivery is there, occurred, then you may give. During antenatal period, you should not, other than in pulmonary edema. It's an important point stressed by everyone. Okay, thank you. Thank you.
So one thing regarding proteinuria, even if there is no proteinuria, we can make a diagnosis of preeclampsia with other evidence. But if there is proteinuria, then also we make a diagnosis. No. So can we say proteinuria is not in the field at all?
Not like that. Not like that. 80% of the case of preeclampsia will have proteinuria, which means 20% of the preeclampsia that we diagnose now is without proteinuria. That is why the latest definition of preeclampsia I have given, that is in 2018 and 2021, adding on to the biomarker abnormality as a surrogate for placental dysfunction. So hypertension with organ system dysfunction is preeclampsia. Organ system can be kidney with proteinuria or without proteinuria with other system involvement, including the hematological changes, or with the placental dysfunction as evidenced by the growth restriction, IUD, or the abnormal umbilical artery Doppler. That is the placental dysfunction. Now they have added in 2021 the biomarker abnormality as an evidence of placental dysfunction and hence a sign of preeclampsia along with hypertension. So no more proteinuria is essential component of the preeclampsia definition. Now I don't know how many definitions I have studied in my lifetime. From of the three of the hypertension, proteinuria, and edema. Now edema is gone for everything, but severe edema has got some value there, I still believe, and that is there. So I am keeping on studying several theories, including Page's theory and whatnot I have studied, and it is going on. So there is no end to it. We are happy that some development. Now this development of the placental biomarker is a scientific thing. We were so far depending on some of the science. So hypertension can be due to 101 causes. We took it as one sign of preeclampsia. Proteinuria can be due to so many things. Edema is definitely due to so many. Now there is a definite pathological entity or a marker for definition of preeclampsia, that is the abnormalities of the biomarkers that we are now studying, and it is coming. So that gives a definite pathological entity reasoning, because the theory of preeclampsia is again the failure of the two-stage theory. The second stage is by the trigger of the stress of the trophoblast. Since it's a trophoblast, it produces a systemic reaction to the endothelial dysfunction. It is a very fascinating thing. There are about 20 years of research is going on to this. The man who is from the Madras Medical College, who is now at US, has done the maximum study what is done for this biological
UK, thing. Sir.
That is maybe. No, that's aspirin. This is, I am talking about a person, Karumachi, who is in US. who has studied 22 years on the biomarker study, and he is one of the authority. And he is the one first to report that in preeclampsia there is a high level of abnormal levels of SFLT1 and the ratio. So he was the first to report in about 5 years back or so. Then afterwards, every day there is a new report. So that is going on. So now we have got a definite pathological entity to point to a placental dysfunction or the symptom happening as a sign of preeclampsia pathology. So we were depending on the symptoms or signs, and moreover, these abnormalities of the biomarkers appear almost 3 to 6 weeks prior to the clinical onset of a preeclampsia signs or the biological effects of the preeclampsia syndrome. So that is a definite marker for preeclampsia. Now we are scientifically we can say this is preeclampsia. Otherwise we are depending on the signs which are seen in so many other conditions like hypertension or edema and others. So that is a progress that we are seeing now. There is going to be an end to the confusion of when we do not know anything, or then we will have so many things to talk. So we had so many theories of preeclampsia because we were not knowing what it is. So probably now it is coming to an end, hopefully. Or next year, maybe something else. Yes.
New name also is coming, sir. Preeclampsia. Peter.
Pardon?
New name will come, no?
It's Sangeeta has said it. Sangeeta said it. It's a syndrome of placental syndrome.
Angiogenic placental syndrome.
Yeah. Good contribution.
Recently, I had the fortune to look at a 1924 MBBS labor room record. നമ്മൾ സ്റ്റുഡൻസിന് കൊടുക്കുന്ന പോലെ പണ്ടത്തെ കാലത്ത് it was called midwifery record. And there they didn't even have proper antihypertensives. So they kept giving enemas to get the BP down, and sadly in the end, very beautifully written, sadly patients succumbed. We've marched way ahead from those days.
You must see the work of Menon.
That's 61, sir. Yeah, that's 61. It's 1924.
No, that is true. So if you follow Menon's work, which he has given as a summary in one of the Royal College oration that he has given in London, which he has struggled through all throughout, what his opening sentence is that I don't have anything new, but it is important for me to talk about hypertension and pregnancy and eclampsia, which we are still losing mothers, young mothers. That was his opening sentence. So the whole oration is printed in the British Empire Journal at that time. It is known as the Journal of British Empire or something like that. It was there. So I could get this thing, and that is all. His struggle of the whole period of his struggle, giving the Maxel. We used to give Maxel also, but by rectal enema. He never got the information of parental Maxel, but he tried it. Then termination of pregnancy by cesarean section was one of the serious. So many things he has tried and helpless. And Lytic cocktail is gone forever, but that is why what we have thought that we could save some lives at that time. So it's a long struggle of the great people. We are now sitting on their knowledge and shoulders. Okay. Thank you, Dr. Prasanna, for this wonderful opportunity of seeing you and talking with you.
So, Bina Kumari, ഇവിടെ ആരും ഇല്ലേ? ഞാൻ കുറെ പേർക്ക് ഫാക്കൽറ്റി ലിങ്ക് ഒക്കെ അയച്ചിരുന്നു. Chat box. How to manage pulmonary edema due to preeclampsia, like any other pulmonary edema. Lasix. Excellent presentation, Sangeeta. Should we start 75 milligram aspirin in view of the dyspepsia associated with the hyperemesis? If you cannot tolerate, of course, you get to reduce the dose. Crisp and lucid presentation. The 150 milligram at night is the standard. This is the Sangeeta answer. I don't know. Excellent. Nothing else. Post to panelist. Okay, that finishes.
Somebody was talking about the kidney injury is seen more because you should not give analgesics, that is
NSAIDs.
NSAIDs should not be given in severe preeclampsia and eclampsia. That is one point that we can think about. You said about the exercise. One of the preventive strategies, the people who are having BMI of 30, they should try to, or if there's a chance, reduce the weight before becoming pregnant. That because that BMI of more than 30 is considered as a risk of developing preeclampsia. That is one of the preventive strategy if you happen to see somebody before pregnancy. That is, if they are planning.
Obesity is very rampant. We have 100 kg, 110 kg, 120 kg.
If they plan to become pregnant, they have to bring down because it brings down the incidence of
So many
diabetes as well as preeclampsia. Both are the things.
Thrombosis,
Sangeeta,
pulmonary embolism,
yeah.
respiratory
Sangeeta has stressed the point of postpartum follow-up of the person who had preeclampsia because it has to be a lifelong yearly checkup because these patients are at high risk of developing cardiovascular disease as well as the metabolic disease. They have to change the lifestyle or improve the lifestyle, exercise, diet and other things because it is proved or shown by some studies reported in the FIGO journal that the lifespan of a woman, unfortunately, it is written there. I am not trying to frighten somebody. The lifespan of somebody who had a preeclampsia and eclampsia is reduced by 10 years. That is the report. If so, we have to be very careful in the postpartum period, counseling the patient to have careful lifestyle and having checkup because they are at high risk of developing metabolic syndrome, hypertension later on in life. And it is said that up to 5 years, 10 years, but it is lifelong. Every year checkup has to be advised, counsel to these patients so that they can improve and have the normal improve the lifespan. Sorry. Sorry. So after delivery, don't think that we have done our job. It is our duty to tell the patient. They will come back to us. So we have to tell them, counsel them properly to have good lifestyle has to be followed.
If she had magnesium before delivery, after in the puerperium she complains of headache and the BP is high, but we again started on labetalol, IV labetalol and magnesium. Not be any delay because that will cause cerebral hemorrhage and we may lose the patient. Okay, we'll wind up, sir.
Yes, great.
Thank you, sir. Thank you, madam.
Thank you. Thank you,
Thank you, madam. Thank you very much. Thank you, everyone. Thank you, sir.
എവിടുന്ന് വരുന്നു?
ഞാൻ ഇവിടെ ഉണ്ട് madam. Video
He
off
was
ആണ്.
there. I was looking.
ഞാൻ വിളിച്ചിരുന്നല്ലോ.
He was listening to everyone throughout. He is not only a endoscopist, but and Kunjumaidin also because they encourage people to become pregnant and they have to be responsible for, responsible means looking after this pregnant women also, not responsible. Not
directly
for the
responsible,
pregnant,
sir.
not the
directly responsible.
responsible for the pregnancy, but looking after that pregnant woman, it is your responsibility also. So I was watching both of you. You were listening. That's a good thing to know.
Yeah, I was here, sir, throughout.
I know. Subhash was also there. Good.
Thank
Good,
you, sir.
Subhash.
Thank you very much, ma'am. Thank you very much, Sangeeta madam. Thank you very much, Kunumadin sir, for the link this today because we had no problem. But one thing we must all remember that we still have about 200 members here. Kunjumadin sir had already prepared an YouTube link and send it to me that if we have people more than 500, so automatically the YouTube link was also ready. So sir അത്രയും പ്ലാനിങ് ചെയ്തിരിക്കുകയായിരുന്നു. ആള് കൂടിയാല് നമുക്ക് യൂട്യൂബ് ലിങ്ക് എല്ലാം റെഡിയാക്കി വെച്ചിട്ടുണ്ട്. So thank you, sir. Thank you very much for your forethought and for all the help, sir. Thank you, sir. Thank you very much.
അത് മാത്രമല്ല മാഡം റെക്കോർഡിംഗ് വേറെ പോസ്റ്റ് ചെയ്യണ്ട, ലിങ്ക് പോസ്റ്റ് ചെയ്താൽ മതി. അപ്പോൾ ഇറ്റ് വിൽ ബി ദർ ഇൻ ദ യൂട്യൂബ്.
Okay, right. And we'll start getting advertisement charges also. for the K4.
Sadi madam ready ആയിക്കോളൂ.
Yes, yes. More members means we will get money.
ഞാനൊരു 20,000 റെഡി ആക്കിയിട്ടുണ്ട് മറ്റേ ജേർണലിന് വേണ്ടി.
താങ്ക് യു മാഡം, താങ്ക് യു വെരി മച്ച്.
തരാം.
സംഗീത ഇപ്പൊ തുള്ളിച്ചാടും.
ഞങ്ങളുടെ പാവം സൊസൈറ്റി
സംഗീത മാഡം,
ഏറ്റവും
that was super.
Thank you so much. Thank you.
Thank you, ma'am. Thanks a lot.
Thank you.
Bye. Bye.
Bye-bye.
Good night, sir. Good night, everyone. Good night, everyone.
Night.
Thank you, Sangeeta. Thank you so much.
Thank you, madam. Good
Thank
night.
you, sir.